Good evening, and thank you for joining us tonight. We are pleased to present this webinar titled Advancing Lasers for Skin of Color. Our special guest tonight is Dr. Douglas Wu. Dr. Wu is a double board-certified dermatologist in both Canada and the USA, with specialty training in cosmetic surgery. Dr. Wu also holds a PhD in clinical immunology from the University of Oxford. He has authored numerous medical articles and textbook chapters and lectures at major conferences across the globe. As Director of Research at the practice, Dr. Wu supervises between 20 to 30 ongoing clinical trials at any given time, placing him at the forefront of discovery and innovation in cosmetic dermatology. With that, I'm very pleased to introduce Dr. Wu.
Thank you so much, Joanne, for that kind introduction, and thank you all for joining me tonight. This is going to be a really cool little webinar here, based on lasers for skin of color, and revolving around our PicoWay system. And so, let's situate it here. So just full disclosure here, serving as a speaker for this session with financial compensation from Candela. So I assume that the reason many of us are logging into this session here today is because we're noticing that there is a sizable portion of our practices that come to us who are essentially skin of color. And census data, at least in the US, has shown that this proportion of patients will continue to increase at a regular rate until about 2060, where it's going to be essentially a majority of patients coming into our practices could potentially be skin of color. And these patients will have very unique sort of concerns, and most of their concerns will center around pigmentary issues. And so by skin of color, we're speaking of spectrum of skin types from 3 to 6 or so. And all of these difficult types of problems, such as melasma, caveolae macules in skin of color, and the dreaded PIH, or post-inflammatory hyperpigmentation, we're going to see them increasingly more in our offices than we already do. And historically, many of these conditions have been very difficult to treat, and our options for them have been rather limited. Post-inflammatory hyperpigmentation, in particular, is a major concern. It's a concern that is sort of the bane of many of our practices when we deal with patients with skin of color and we consider laser treatments for them. Essentially, what happens with post-inflammatory hyperpigmentation is that the dermal-epidermal junction of where the melanocytes reside get injured by laser and cause a hyperactivity of melanocytes. And this phenomenon is much more common in patients of course, darker skin types, essentially 3, 4, 5, and 6. And PIH can be seen in response to almost any laser or almost any invasion or disruption of the DEJ by any modality. And especially in ethnic skin types and in ethnic populations, the development of PIH can be extremely distressing. Especially if we unfortunately are the ones to induce such PIH. So the risk factors that contribute to PIH development have been studied in relation to laser. And of course, the laser that is used is one of the main determinants. Aggressive lasers that ablate the dermal epidermal junction, causing maximum injury to that area, such as CO2 and erbium YAG, YSGG, etc. Those types of lasers tend to have extremely high risk. It's also been shown that the density of the laser, when we talk about fractionated lasers, tend to also play a big role in the development of PIH. This was work coming out of Henry Chan's group and several others, showing that the higher the density, the greater the risk there is for PIH. And that makes sense because the higher the density, the greater continuous disruption that we get of the dermal epidermal junction. Fluence also plays a role, likely less than density, but still certainly a consideration. In addition, the time period in between laser treatments is also thought to contribute to the risk of PIH development. And this also makes sense because we really want to give these patients the time to recover from the injury that we're inducing. And so sometimes we need to sort of space these treatments out a little bit longer in order to avoid PIH. And finally, this is basic laser physics and understanding, cooling of the skin or protection of that epidermal layer with a variety of means, either forced air, contact, or cryogen spray. Amongst those are the three probably most common ones, tend to be very important in determining the risk for PIH. So we've been obviously using lasers. All of us have been using lasers for a very long time, they've gone through many successive generations, from kind of the millisecond domain lasers, which dominated the initial sort of development of laser dermatology, and operated on the principle of selective photothermolysis. And were actually very effective at targeting many chromophores within the skin to achieve great effects. The Q-switch lasers, popularized in the 1990s, but developed even decades before then, were able to adjust that pulse duration down into the nanosecond domain. And that became actually fantastic because when we adjust the pulse durations down to the nanosecond domain, the tissue interaction dramatically transformed from one that was predominantly photothermal to one that became predominantly photomechanical or photoacoustic. However, even with the most advanced Q-switch lasers with the shortest nanosecond domains, a significant amount of non-specific photothermal damage was still evolved, and so therefore we could see the well-known complications of Q-switch lasers, including hypopigmentation, hyperpigmentation, and scarring. And so over the last few years, commercially anyways, picosecond lasers have been developed, and to have a laser with a pulse duration in the picosecond domain is phenomenal, because the amount of energy that is transferred into photomechanical effect finally becomes the majority, and very little of that energy residual is for photothermal effect. And therefore, the risk of these complications becomes much lower. So there are drawbacks with certain laser technologies within darker skin types, and I'm sure many of us, if not all of us, kind of have knowledge of this. The traditional ablative lasers, the erbium YAG and the CO2 lasers, both fractionated and non-fractionated, have extremely high risk for PIH in skin of color. Not to say that they cannot be used, but they need to be used with caution and with the understanding that no matter what we do, in order to achieve a clinical effect, and if we select this treatment modality, then our patients will be facing a significant period of downtime, not just due to the healing from the treatment, but also from the development of PIH and other pigmentary alterations. Further developing from that, from the ablative technology, was the fractionated non-ablative technology, the most common of which is the 1550 nanometer erbium doped erbium glass laser. But there are a variety: 1540, 1560, 1565, 1320, etc. A lot of these non-ablative fractionated laser modalities, which have a lower risk for complication and pigmentary alteration than the ablative lasers, but still operated entirely on the principle of photothermolysis, and still in skin of color ended up having a significant hyperpigmentation risk. Q-switch lasers were fantastic because, again, they could target the melanin very specifically, but again, the risk of hyperpigmentation, especially compared to the long pulse lasers previous to them, was actually even higher. And so then we come to the picosecond laser now, which, due to its ability to sort of focus mostly on photomechanical effect as opposed to photothermal effect, has been shown to have a reduced risk for the development of pigmentary alteration. And the risk profile is almost more similar to the long pulse laser, but the effectiveness is much higher. So we kind of get the best of both worlds. What are the characteristics of ideal lasers for skin of color? Well, it all comes down to the parameters. The ability to target a specific chromophore with the minimum amount of energy in order to ablate that chromophore with the shortest possible pulse duration. And that, in a nutshell, is the goal of essentially all of our laser surgery. And the PicoWay laser, as one of the premier picosecond laser systems currently available, fulfills those criteria in probably the optimal way. It has the shortest pulses of any commercially available picosecond laser. And that holds true throughout the wavelength range of the device, from 532 to 785 to 1064 nanometers. All of these wavelengths have picosecond pulse durations of under 500 picoseconds, which puts them significantly shorter than anything else that's currently available. And so this essentially translates to the ability to provide a safer treatment, a less painful treatment, as well as less treatment numbers that are typically required. It's been cleared in many varieties for a variety of different skin types, and this kind of speaks to, first, of course, the safety of the device, but also the commitment in developing this device to try to address this outstanding concern that we all have with our patients with skin of color. And as you can see here, the 1064 nanometer wavelengths have been approved even up to and including type 6 skin for tattoo removal, whereas the Resolve handpieces, the fractionated handpieces, have been approved up to type 5 skin. And so we're getting into those very difficult to treat, even type 4s, very difficult to treat skin of color patients for a larger variety of indications, such as pigmented lesions, acne scars, and wrinkles. And there have been several reasonably well-designed and well-powered clinical trials over the last few years that have shown the ability of the fractionated and non-fractionated PicoWay laser to improve many of these conditions. As you can see here, in one of the very first papers that was published, it was a small letter to DermSurg published by actually myself and my colleagues, where we analyzed the incidence of pigmentary alteration following picosecond laser essentially it was actually mostly Asian, some Hispanic patients for treatment of essentially lentiginous, and found actually a very low PIH risk, extremely low PIH risk in this particular study. And then in the seminal sort of tattoo studies, you can see here that treatment, even in skin of color, results in very minimal pigmentary alteration at the end. And many of us probably have experience treating tattoos with the Q-switch lasers, and a little bit of hypo or hyperpigmentation following tattoo removal was almost unavoidable, given the length of treatment duration and the number of treatment sessions that we had to achieve with the nanosecond lasers. So this was a significant improvement. Acne scars, a patient like this presenting with acne scars, a skin type 5 patient, our options tend to be very limited unless we have a very frank discussion with this patient about how much PIH they're going to get and how long it's going to last, typically months after a traditional, either ablative laser treatment or non-ablative fractionated laser treatment. And so the fractionated picosecond laser can really come in there with minimal injury and achieve a very nice clinical effect while minimizing downtime. And wrinkles as well, also in the fractionated sort of modality. So there are several things that I would strongly recommend that we consider when we treat patients with skin of color in order to minimize the possibility of pigmentary alteration. The basics are, of course, proper patient selection, proper patient counseling, selection of the correct device and wavelength, as well as selection of the correct settings and parameters, as well as potentially, in select cases, choosing to test areas that maybe are not as cosmetically sensitive prior to actually treating larger lesions or larger surface areas. But in terms of what we can actually do as interventions to minimize this risk, topical treatments have a big role to play in terms of pre and post treatment with bleaching creams or fading agents, hydroquinone being, of course, the sort of the number one agent that has been used. But there are many others currently that are non-hydroquinone based that in fact even have been compared head-to-head with hydroquinone in clinical trials that can fade pigment and prevent the development of excessive melanin production following laser. Topical steroids following laser treatment have been shown convincingly to decrease risk. And, you know, using appropriate sun protective measures cannot ever be overemphasized. This is always going to be a very, very important thing to consider with our patients. So there are a lot of things that we as physicians can do to minimize the risk for our patients, and it's the picosecond laser and the Picoway in particular plays a key role in that. But we can't obviously say that, well, this laser, we can just do whatever we want with it and it'll have no risk. We also, of course, have to keep in mind our common sense and all the other measures that we can take to augment the ability of the picosecond laser to be as safe as possible. So there are some things about this laser system that actually are quite attractive. I use it daily in my practice for treatment of skin of color. But the adjustability of this device, probably many of us own or use or have experience with this device, and perhaps other picosecond laser devices are currently available. But the versatility of it, in fact, in the ability of the zoom handpiece, as well as the resolve to be imminently adjustable through multiple spot sizes and multiple fluences with no compromise in terms of the peak power and the peak fluence, as well as quick treatments. Even the larger spot sizes can achieve reasonable fluences, and therefore leading to less time on our part to treat larger surface areas. These are all issues with the picosecond lasers in general. The Picoway seems to address them in a very, very good way. One thing that I've always appreciated about Syneron Candela is the support that they show to the people who have purchased their systems. I use the Picoway, but also other systems of Candela, and the training that they provide and the support and all that has always been very, very good. So that's something also to consider when thinking about a system in general. But I'm very happy to sort of speak on this issue. It's something that I deal with every day in my clinic. It's something that has improved significantly since the advent of the Picoway laser into my practice. I've used a variety of different picosecond lasers, and I've essentially those ones get no use anymore because the Picoway has managed to sort of rise to the top. So thank you so much for joining me this evening. I would love to sort of field any questions that anyone has, or kind of chat a little bit more about anything else that is picosecond laser related.
Thank you, Dr. Wu. So yes, at this time we will open it up for questions. If you haven't done so already, feel free to type your questions into the Q&A panel. Our first question tonight looks like, what are you using to treat patients who come in with scarring induced by another type of laser?
Right, so great question. Now, to answer that question, I guess we should take a step back and consider the different types of scars that can develop. Okay, and so there are many different types of scars that can develop from laser treatment. I assume the question is trying to focus on hyperpigmented scars that develop from other surgical or laser treatments. And so for hyperpigmented scars that develop from these types of treatments, then in fact the fractionated picosecond laser, i.e. the Resolve handpiece, I have used to great effect, extremely low fluences, low densities, and in combination with a mild topical bleaching agent, the effects are astonishing. Actually, I recently presented this work at the annual meeting of our Laser Society, ASLMS, essentially, this year, showing the picosecond fractionated Resolve handpiece treating hyperpigmented scars in an African-American man on his shins. One treatment and a little bit of bleaching cream, and they completely resolved. But not to say that that happens with every scar. Of course, scars are stubborn. But that would be where the Resolve handpiece would really shine in such cases. The other types of scars, obviously erythematous, hypertrophic, atrophic, those would be best addressed by different modalities.
our next question is, do you treat melasma with peak away? What are your settings? What is the success rate and protocol, please?
That is the million-dollar question. So the brief answer is yes. I do treat melasma with the peak away system. And in my opinion, the only safe way to treat, and this is debatable, but the only, in my opinion, safe way to treat melasma with the picoway laser and with any picosecond laser is to use the fractionated modality, okay, and to use low fluence and low density combined concurrently, just like with any laser treatment or any treatment really with melasma, combined concurrently with sun protection and a bleaching cream, and to do slow incremental improvements at 2 to 4 week intervals and 4 to 6 treatment sessions. If we follow all of these steps, then the control that we can achieve for the melasma and the resolution that we can achieve for the melasma can be very, very pleasing. It's never a cure, however, and that has to be communicated clearly to our patients. It's always going to be an issue of maintenance, and so I always tell them, you know, every 6 months after the initial series, we'll probably do another laser just to touch things up and to keep things nice. We'll try to stretch that out result as long as possible with bleaching creams and sun protection, etc. But every 6 months or so, that's when they'll come back for another treatment. And so the short answer is yes, you can use the picosecond laser, picoway laser for melasma treatment. I strongly recommend sticking to the fractionated handpiece. And the reason for that is because using the so-called low fluence laser toning that is popular, and not saying it doesn't work, there is risk with any laser, including the picoway laser, much more, of course, with the nanosecond laser, but including the picoway, that there is a risk for inducing a mottled hypopigmentation. And this is essentially an irreversible complication, and that is completely eliminated if we use the fractionated handpiece. And so that would be my suggestions on how to approach melasma with the picoway laser.
Right. Setting expectations, and it's not an easy cure, right?
Absolutely.
So the next question is, what spot size do you start black tattoos with?
By and large, so I guess the first answer should always be you start with the minimum amount of energy and the largest spot size to achieve your optimal clinical endpoint, which is instant, opaque, bright, dense whitening of the skin. And so, even with that in mind, any setting or any spot size or any fluence that can achieve that clinical endpoint will achieve effective and safe resolution of the tattoo, as long as we're following the guideline of using the minimum sort of energy to achieve that endpoint. Practically speaking, I usually start around 4 millimeter spot size and anywhere between 2.4 to 3.2 joules per centimeter squared of fluence.
Okay, and the next question is, do you ever do multiple passes of one tattoo with multiple wavelengths, like a pass of 1064 and a pass of 785 on a tattoo? If it's a dark green, for example, or dark purple?
Great question. Absolutely. And this protocol actually was invented, to the best of my knowledge anyways, by a dear mentor of mine, Dr. Richard Fitzpatrick, who unfortunately has since passed away. But the multiple pass tattoo removal technique was first published by Dr. Rox Anderson back, I think, in 2008. Where, you know, not different wavelengths were used, but single wavelength was used over multiple passes, 20 minutes in between each pass, the so-called R20 method. But yes, I do use multiple wavelengths, and the way to do that is to go, you can either go deep to superficial or superficial to deep. It doesn't really matter, but you have to wait for the frosting to dissipate, or you have to use the perfluorodecolon, otherwise known as describe patch, to instantly eliminate that whitening. Otherwise, it'll block the laser. But absolutely, I do blend lasers routinely for tattoo removal, and it's safe and it's very effective.
Thank you. The next question here is, can you or have you used the Picoway to remove or reduce keloids?
So the Picoway does have a role in reducing keloidal or hypertrophic scars. And the only way it has that role is in the fractionated modality at probably actually higher fluences than you would generally use for general rejuvenation. However, I wouldn't say that the Resolve or the Picoway would be my go-to option for hypertrophic or keloid scarring. At my practice, I have the luxury of having about 50 different lasers or energy devices, and if hypertrophic or keloid scarring is a large component of your practice, then I would direct you to. There was a good article in the Journal of the American Academy of Dermatology, published back in 2014, an expert consensus guideline on how to treat hypertrophic scarring, combination of fractionated laser, injections, pulse dye laser, stuff like that, which is the optimal way to go. But if I had to use the Picoway laser, it would be the Resolve at high fluence in combination with injections of either triamcinolone or 5-fluorouracil or combinations thereof.
Thank you. The next question is, would you use this for a skin phototype of 4 or higher for post-inflammatory hyperpigmentation after a chemical peel?
Yes, with caution, and only with the fractionated handpiece, like the case that I described that I presented earlier this year in a type 6 individual with hyperpigmented scars.
There's a few more questions about melasma here, but one in particular asked if you require a patient with melasma to have a recent blood panel before treating them with Picoway?
I do not. I absolutely do not.
Okay. And then the other question here is mentioning, you mentioned the use of topical bleaching treatment. Do you recommend it prior to laser treatment and after treatment?
Definitely concurrently and after treatment, yes. Prior, I do also try to do 2 weeks of treatment prior to laser exposure.
Okay, and I think the follow-up question to that is, does the bleaching treatment need to be stopped a few days prior to treatment to avoid laser wrist sensitivity?
Absolutely not, and the caveat to that is one of the most popular bleaching regimens is this modified Kligman, essentially with hydroquinone, a topical steroid, and a retinoid. The retinoid can itself be irritating, and so if the retinoid is irritating their skin and they present for laser treatment with irritated skin, then that would be, in my opinion, a contraindication to beginning laser treatment. Because then their risk of PIH is even higher because they're already irritated. I tend to use a non-hydroquinone, non-retinoid-based bleaching cream, and therefore I don't have that problem. And so that's something that we have to use our clinical judgment to tailor to each individual patient.
Thank you. The next question here is, do you put numbing cream on a lot of your clients?
Oh yes, absolutely. Everybody.
Makes it much more tolerable, yeah?
Absolutely.
So the next question is, does it have any applications for post-inflammatory hyperpigmentation post-sclerotherapy?
Oh, that's a really good question. So post-sclerotherapy hyperpigmentation is due to hemosiderin deposition and not melanin. Typically, well, mixture, but typically more hemosiderin than melanin. And so what I have used with success is the 785 nanometer wavelength to disrupt that hemosiderin, to shatter it, and to clear post-sclerotherapy hyperpigmentation. Analogous to, there have been reports in the literature, 755 nanometer, like alexandrite lasers, etc., to target. It's a similar concept to that, but you get the added benefit of a 300 picosecond pulse duration laser, which makes it even safer.
Thank you. Let me see here. I think I'm getting some in the chat window as well. Do you combine with any before or after creams to help the melasma, like hydroquinone or anything else?
Yes, absolutely, always. In fact, any laser treatment or any treatment period of melasma, in my opinion, should be combined with sun protection and an appropriate fading cream at minimum.
Okay. And then another question regarding melasma is, have you used cysteamine for hyperpigmentation or melasma?
Cysteamine.
C-Y-S-T-E.
C-Y-S-T-E. Let me see. If you permit me 2 seconds. C-Y-S-T-E, cysteamine. Clearly I haven't. Let's see. I'm afraid not. I'm unfamiliar with this medication.
Okay. Using an IPL, can you translate the same idea in the choice of higher fluence, lower energy, and darker skin for hyperpigmentation?
I beg your pardon. Using the IPL?
Using an IPL, can you translate the same idea in the choice of higher fluence and lower energy and darker skin for hyperpigmentation?
So I guess the strict answer is technically yes. With the IPL, if you wanted to treat skin of color in the safest possible way, then you would have to choose a high wavelength cutoff, 600 plus, 620, etc. plus wavelength cutoff filter. You would have to significantly decrease your fluence. And you would also, if your machine allows, have to increase the pulse delay between pulses of IPL significantly. And so IPL for darker skin types, especially 5s and 6s, is something that you would have to be very cautious with, and you'd have to be very confident in your device. You would have to know your device very well, and have a significant amount of experience, probably again through painful trial and error. But yes, it can be done if you have no other option. But the Picoway laser, you don't have to worry about all of those difficulties, especially the fractionated Picoway. Because IPL will almost never be fractionated.
Thank you. And I'm probably going to butcher the name of this, but do you prescribe oral tranexamic acid for patients being treated for melasma?
Yeah, so oral tranexamic acid. Good question. That is one of my sort of fallbacks or second lines that I will consider for cases of severe melasma, and not alone, but in combination with bleaching cream, sun protection, laser, potentially even the lycopodium extract for further sun protection, stuff like that. But yes, it can be. Know that, of course, it has the potential for thrombotic risk, and so a more detailed history, possibly physical examination, things like that need to be kept in mind before prescribing this medication. And when I do use it, I don't use it endlessly. I've set a finite period for its use.
Thank you. And we have, which ingredient for melasma do you like the best?
hydroquinone is the most tried and true. We did 2 head-to-head clinical trials comparing 4% essentially a triple combination 4% hydroquinone preparation versus a different commercially available non-hydroquinone lightening cream called Lytera, and they perform equally well. So that's my other go-to. And then the other products on the market, kojic acid, arbutin, azelaic acid, Allure, etc. I'm sure are fine as well, but there's not as much clinical data behind those other ones. So I basically stick with hydroquinone and Lytera.
Okay. And I think this is one of my favorite questions on here is, which specific Pico laser do you use?
Oh, I've used, to be fair, I've used extensively both the Pico Sure and the Pico Way, and I have used less extensively the others that are available in the US, but by far the Pico Way laser is essentially almost the only one I use now. Prior to the 785 nanometer handpiece being developed, I did still use the Pico Sure for some blues and greens, but nothing else. For rejuvenation, scarring, hyperpigmentation, tattoos, the Pico Way is superior by far in almost every aspect.
I love the sound of that. So we have more questions asking about your parameters for melasma. However, for those that have missed it, we will be sending out the recording to everyone so you can hear the entire presentation as well as all of the wonderful questions that you have asked and Dr. Wu's answers for those questions. It doesn't look like we have any other questions at this time. So if any do come up, feel free to reach out to your local representative, and we will definitely get those either to Dr. Wu or they can answer them for you. A special thank you to Dr. Wu for sharing your personal experience with us, and we thank everyone for joining us tonight. We hope everyone has a wonderful evening.
Thank you very much.
Thank you.